We are back for another session with my friend, Dr. Sunita Puri, who is the medical director of the palliative medicines and supportive care service at the Keck Hospital and Norris Cancer Center, the University of Southern California, but also, and many other things, but also the author of a beautiful book called That Good Night. Thank you for being here, Sunita.
Thank you so much for having me, Michael. I'm glad to be with you all.
Absolutely. And now the people that have called or just watching, you can answer a question at any point in the Q&A, and we'll try our best to get to them. We're going to start though with your book. Talk to us about the inspiration and what it was like to maybe take a pause in your life, or maybe you had to do it in between shifts, and really the inspiration and the impact, what it has been like for that to be out in the world.
Totally. So I kind of was always a writer and inclined towards the arts before I came to medicine. And I journaled and wrote pieces throughout my training just to kind of make sense of what I was seeing. Because especially when you go from learning the facts of medicine to seeing patients, it can be a jarring jump. And so I started doing that, and I wanted to write a book that captured why I went into palliative care. And when I did the digging, a lot of it came from growing up with immigrant parents who were deeply spiritual. And so coming from an environment where I was taught early on that death is inevitable, and embracing it rather than raging against it helps you to live your fullest life. And then I went into medicine where the opposite was true, where raging against death was the point. And that's how we were socialized. And so really trying to make sense of that was where I started. And one of my motivations was to write the sort of book that I wish I had when I was in my training, to kind of normalize what it's like to not be trained to have incredibly important conversations with people about what they want for themselves at the end of life, but also how to live well up until their last breath. And so a lot of what I do in the book is examining my own failures in trying to have these conversations with no training, and then what it was like to have the conversations, but to learn that it was the attention to language that mattered the most.
And we've had Rana Adish on this series and had her talk to us about just really having to model language for others, which I imagine you've done a lot of. And let's delve into that a little bit more specifically. When you think about how important the language is when it comes to these conversations, what comes to mind?
So I think right off the bat, being very kind of intentional about how you frame a conversation with a patient and their family. And what I mean by that is that I have often observed that my colleagues will walk into a room and just start talking without having thought about what is the goal of this conversation? What are the things I want to communicate? What are the things I want to listen for? And how can I weave that all together to come to a plan that integrates my medical recommendations and the preferences and goals of the patient? And so I think of these conversations as a procedure. They're no different than a surgery, and there's a way to do them. And words are our tools rather than scalpels or drills. But words can also be scalpels or drills. And so when I go into a conversation, I really try to understand what people know about their illness, not make an assumption that what I know is what they know. And then from that shared point of understanding, asking them what they're hoping for in this situation, and having the kind of moral courage in a way to be very honest with them medically. And that includes saying things like the words dying and death. It includes saying things that are not euphemistic. And I think in medicine, we talk around the truth a lot because it's hard for us to be direct. But as I'll often tell my patients, the time for transparency is never more important than when someone is in the ICU. So I think that's how I approach it. And when people say things to me like, I'm a fighter and I want everything done, instead of assuming what that actually means for different people, I ask, tell me what being a fighter means to you. When you say you want everything done, can you tell me what that looks like? And very importantly, we are doing everything, but your loved one is still dying. And I want to talk about how we can move forward with a plan that offers them compassion and dignity given what their body is showing us. And so these are the sorts of things I did not learn in my training, but I kind of had to teach myself and build on it during my palliative care fellowship.
Yeah. I mean, incredibly powerful. The word moral courage is ringing out to me. But the also, I think whether you're a clinician or whether you're talking to your aging parents or your best friend or your spouse about their end of life wishes, whether they're in the ICU or they're just having a regular Tuesday afternoon. That level of intentionality you talk about from a clinical perspective is actually incredibly useful for us. Just having, this conversation is an elevated conversation. What how has this translated to how you talk to just the regular people in your life when they're not, your patients?
So you mean like my family and others? So yeah, one chapter in my book talked about me having this conversation with my parents because I had just taken care of a very lovely Indian woman who had suffered a massive stroke. And I was helping her children kind of make decisions about what we should do next. And I think it was the combination of my sense of familiarity with the family, culturally and otherwise, and then just what happened out of nowhere to a very vibrant woman that made me want to really advance that conversation with my parents. Like I had a sense of what they wanted, but I got more granular there. And the way I generally frame these things with people that I care about, whether it's family or friends, is that, I see every day in my work that people's lives can change in an instant. Sometimes that's a car accident, sometimes it's a heart attack out of nowhere. And I think I want to know how I can be your advocate and your voice if something unexpected happened to you. And I try to frame it that way very gently because I think these are conversations that can be very intense and morbid for some people. So I think coming at it from a point of love and grace to say, I'm not coming at this from a place of fear, even though I might be afraid. I'm coming at it from a place of loving you deeply. And having this conversation is like an act of intimacy. It's going to a really hard place and promising that I'll be there with you in that hard place. So saying things like, I want to be your voice. I want to understand that if something really unexpected happened to you, what sort of life would you want for yourself? I know that you love watching Hindi movies, right? Or, eating my mom's cooking, whatever it is. So what if your ability to do those things was compromised by how sick you are? When you come to the very end and God is calling you, would you want me to advocate for you getting CPR or being on a ventilator or dialysis? And I think, again, kind of asking for specifics and also knowing that situations and opinions might change and allowing for that too. And I think that framing it also as a dynamic conversation helps to take away the pressure that there's some sort of finality with the decisions made right then. And, sometimes I think it's helpful also to point to other deaths in the family or in popular culture, right? So, I once advised a patient to ask his wife, because she had metastatic pancreatic cancer. And, Alex Trebek was very open and public about his experience with it. So I said, what if you talk to her about Alex Trebek and his attitude and the things that he said about his treatment and what he wanted? And does any of that resonate with her either as something she'd want for herself or something she wouldn't want? Or, grandma died on a ventilator. What was that like for you to see her like that? Is that something you would want for yourself? So, kind of trying to make it specific and granular, I think, is very helpful when we're talking to people we love.
Yeah. No, and I think in both cases, what's missing, and it's good that it's missing from your methodology, is the should, is the directionality, is the coming to it and thinking that like people come to their parents and be like, we need, or their spouse, we need to have these conversations. We need to have the conversation. We should have this done. And what you're showing in both cases is this, is starts with listening and an
Yeah.
open-ended question, and about advocacy and emotional statements like I want to be your voice, like is a very, very powerful thing. Not like we need to do our advanced care directive.
Exactly, because that sounds so dire and final to people. And these conversations, when done early, especially, they're very dynamic. And there is space also to say, hey, I'm really worried that with all of your conditions, if your heart did stop, I don't know what CPR would do for you. Like being able to kind of go there too and challenge what people might be saying is their wish. I think that's also really, really important. And again, because this is a space of intimacy, there is that back and forth.
Yeah, absolutely. I think of these conversations as a kind of courtship, where it takes that kind of effort. You may get rejections along the way, but you have to be creative.
Exactly. That's a great frame for this.
Well, and you also were really indicating, things that matter to the person you're talking to, right? Things that are very relatable. And that's what we do when we're looking for a job or when we're looking for love. Like we
Yep.
think about the person, the job we want, or the person that we have our affection for, and we do things that we think they might find relatable.
Yeah,
Um, so
exactly. No, it's
yeah,
totally that dance and that thinking um, about what's important. And I will say, in my experience, what's important to people tends to be pretty similar. Most people, do not want to live without their mental faculties. Most people do not want to live without some degree of independence. Most people want to be with their families. And so knowing these things really helps to direct what we recommend medically. And I've had to tell people, it sounds like if this is important to you, that this intervention is likely to take that away from you.
right.
And so, can we talk about what that means? And it's always like an invitation, it's always something very gentle. I know that you had asked before we started talking about advice for families in the ICU.
Yeah, let's
And
talk about
I wanted to kind of just explain because I'm pretty sure everybody in the audience is familiar with exactly what palliative care is, but just to go over it again. Um, so palliative care is a medical specialty that addresses suffering in all its forms. Physical suffering, so things like cancer pain, emotional and spiritual suffering, when you're dealing with an illness that might have come out of nowhere or might have been with you for a long time, but understandably, the kind of aftershocks of that diagnosis can be destabilizing. And so we attend to all those domains of suffering for the patient and their family. And we do so with an interdisciplinary team. So on my team, we have a social worker, we have a nurse practitioner, we interact with hospital chaplaincy because we don't have a chaplain of our own, and we have a physician. And we have tons of learners. So in the background there is Matt, who is a family medicine resident. And say hi, Matt. So this is kind of important to have young physicians in training see what we do, because the majority of physicians I interact with do not really know what palliative care is and have not been trained in it. So it's not their fault. They just haven't had the exposure. And so in a setting like the ICU, the way it generally works is the ICU doctor or team will call me for my help. So I can't really get involved unless someone requests my help. And I think that's important for families to know, because you can request that your ICU team call palliative care. And the reasons to call us would be for support and guidance in medical decision making for the family, but also very importantly, to have a talk with the team about how your loved one is doing and how we hope his or her course in the hospital will turn out. That way, we can help you to make decisions based on your total understanding of exactly what your loved one's going through. And I think because we do not, as physicians, get a whole lot of training in expert communication around these sensitive topics, that without help, sometimes you may be making decisions without a full appreciation of everything going on. Or you may be asked, what do you want us to do? Which is a lot of pressure to make decisions with potentially not a full appreciation of the implication of those decisions. So what I do a lot of the times is really help my colleagues and help the families to get on the same page and to make decisions when we are both kind of fully informed about each other's hopes and expectations. And I think that, at every hospital, the composition of the palliative care team looks different. So there are some places where there's just an RN as the whole palliative care team. There's some places where we have a full cadre of clinicians. So it does depend, but it is always your right to ask for a palliative care consult. It is also your right to ask for a formal meeting with the physician taking care of your loved one, any other physicians who might be involved. Like, let's say your loved one's also on dialysis and just got a big cardiac surgery. It is your right to say, I would like a formal sit down to understand everything going on. And that is something you should request, whether or not palliative care is involved or available. And I think my advice at those meetings is to write down your questions beforehand and ask them, because your physicians ultimately, I very much believe, want to do the right thing for you and for your loved one. But you also can ask them to sit down and explain everything to you, and that's totally within your right.
Well, I mean, that's, I think, probably a revelation for a lot of people listening. That and it's news to me that you can ask for those things. Now there's this association with palliative care, both in the hospital and out of the hospital, that it means the person's dying. And there's no relationship really, right? I mean, obviously there's some expertise around serious and complicated and life-limiting illness with palliative care, but my understanding is, if you have a loved one in the ICU who's suffering in some way, in pain, having a palliative care consult does not mean you're saying that they're going to die. Correct?
Exactly. So, typically what I tell people is that I'm a quality of life doctor. And that means my job is to support you living the best life possible, no matter how long you have to live. So if that's at the time of diagnosis, like you just got diagnosed with metastatic lung cancer, then I can help you. And there's actually this is important for everyone to know. I think there is evidence from studies that show if palliative is involved at the time someone gets a serious cancer diagnosis, one of the landmark studies in our field shows that that combination versus just cancer care alone and as needed palliative care, if you do both from the beginning, people actually live longer, an average of 12 weeks longer, and they live better with far superior symptom control emotionally and physically. So, as opposed to this notion that we only get involved at the end, if we're used at the beginning, we can help tremendously. And it is unfortunate that at many places we do get called at the end of life, but that is not reflective of what our field actually does, which is
Right.
helping live well with an illness.
Right. And palliative care is not hospice, but hospice often provides palliative care or almost.
Exactly. You're absolutely right. And hospice, I think of exactly as palliative care when you're in the last 6 months of life. And I think there's a lot of myths about hospice too. Like, I have a lot of patients who say, well, he's still walking and talking, or families that say, my uncle's still walking and talking. Why does he need hospice? And I think that comes down to our national imagination of what dying looks like. Because you can be up walking and talking and be dying and choose to be on hospice to maintain that state for as long as possible. And I think that that's a cultural evolution that needs to continue to happen so that people know when they're actually a candidate for hospice, as opposed to just a candidate for all the interventions that might be being presented.
Yeah. So we've got a question from one of our faithful attendees, Bob Hoffman. He would love to know your opinion about a couple things. The assistance of a death doula, either in a hospital, or at home. And are you now able to integrate? Are you seeing doulas being integrated into hospital care? Let's start there.
So I have personally not. I have a couple of my patients who use doulas, but it was only in the home setting. I have not heard of death doulas coming into the hospital to assist. But that could just be my patient population. I do think that doulas have an important role to play in supporting the patient and the family. I also think it's important for them to work collaboratively with the medical teams that have known the patient for a long time, because I think that's the best way to be on the same page about everything and make sure that the patient is supported by a variety of different people.
Right. You don't want to be working against each other, taking people in different directions,
Exactly.
Right. And so I imagine soon you will see more doulas because there's so many more doulas.
Yeah, no, there's definitely a lot more of them. Yeah.
Yeah. Bob also asks about dying with the death with dignity law,
Mhm.
and what your opinion is. I mean, that's a controversial topic, so I'll let you talk about it however you want to. And we don't have too much time left, but.
So yeah, no, I'm happy to talk about that. I think that, I support people who want to make use of that option 100%, because I think that I have seen certain types of suffering that even the absolute best palliative care cannot always alleviate. When the Death with Dignity Act was first passed in California, I'll be honest that I had reservations because I felt like people aren't even using palliative care appropriately. And so I didn't want that option to overshadow all of the things our specialty can actually do to help people live well. And I still feel that way, that people should be offered excellent palliative care in addition to exploring or going through it with the End of Life Option Act. I don't think the two should be oppositional. And a lot of when I have patients request to go through that, I support them 100%, but I also tell them I want to be sure that if some of the reasoning for this is that you can't live with this pain, that I am also addressing your pain because I don't want you suffering as you go through this process. And usually that is very well received.
Yeah, absolutely. So, any other tips or things that you've seen for a family who's has a loved one in the ICU? What have you seen, especially during COVID time, that you thought, wow, look at that family taking care of themselves, taking care of each other, doing something exemplary that we should, hear about or learn from.
So I think one of the most important things that I saw was that families were together during that time. Because I think even if there was issues with estrangement or other problems like that that predated someone's illness, that ultimately having support from each other, focusing on what their loved one would want for themselves and putting aside differences, I think was especially important in the COVID era because nobody could really visit. Even now, we have a very strict visitation policy. So agreeing to be on the family conferences together, agreeing to, take every opportunity to call in and talk to someone, talk to your loved one, even if they're intubated and on dialysis and they can't speak to you. The nurses here were great about taking iPads in and allowing people to see their loved one and talk to their loved one. And I think the families that really kind of stood out to me were the ones who made that daily commitment. And I think it is ultimately part of taking care of oneself to know that you've done everything you can to connect with your loved one and support him or her. I also think, I had a patient recently, this was a clinic patient who was taking care of her husband who has very advanced Parkinson's. Um, but she told me that her self care was very important to her. It's one of the first things she said, and that she needed my help to figure out ways to take care of her husband that could maximize her self care so she could continue to be his caretaker.
Mm.
And I think that sort of honesty is so important because caregivers and families are kind of the unsung heroes of our patients. And yet our healthcare system really doesn't support or listen to them. So I always encourage my patients after hearing her example that, what are you doing to take care of yourself? There's a variety of things you can do. But I do want to check in and make sure that as you're doing this hard work of taking care of your husband, or that you're going through this experience of your loved one in the ICU, that you are doing even the basics, eating, drinking, sleeping, seeing your own doctor or therapist so that you have support outside of your family unit. I've become a little more vocal about saying that sort of stuff.
Yeah, no, I think it's essential. And so everybody listening, this idea or this almost this script, our loved one is needs our love and support. Let's put aside our differences. You can put them in a box over here and get back to resenting the hell out of whoever after. Or whatever it is, because I know that that's hard for a lot of people. It's like, families do have strife. So quick in closing, I know we're at time and over. There was a question about that landmark study in palliative care space that showed that there was a 12-week extension. How do people find that study?
So I can put it in the chat if you'd like.
Oh, great. Yeah, let's do that.
My RG Experiences team. Oh, let me go to everyone. Okay. Oh God, what did I do? Okay. I think I clicked on the wrong thing. So the study is by Jennifer Temmel. It was in the New England Journal of Medicine. It was August either 2010 or 2011. And it's based on patients with metastatic new diagnosis non-small cell lung cancer. And I think, this is a study that I point to a lot when people are like, well, I don't want palliative care for my patients. And I'm like, well, these are the benefits. The American Society for Clinical Oncology ASCO and the American Heart Association both have pretty strong recommendations for the involvement of palliative care from the time of diagnosis. And if you're getting resistance in trying to get palliative care for your loved one, I would not be afraid to point to those studies. In fact, I would encourage it. And I've done that with my own patients to say, if your oncologist is hesitant, remind him of this study.
Yeah, absolutely. Because there is internal resistance sometimes.
That's a whole topic for another time.
Yes. All right. Well, Dr. Puri, thank you for taking the time and sharing your wisdom.
Of
And
course.
everyone have a beautiful day. Thanks for showing up.
Thank you.
Bye.